Precision in practice, essentials in liver ablation. This is my talk. Let me start with my conclusion slide. Precision is not a technical. It is a mindset. As we all know, liver ablation is accepted as a curative treatment option for almost all treatment guidelines. We should be proud of it. How to achieve zero local progression after liver ablation? For precise ablation, I would say precise planning is the essential key. Complete ablation is achieved not only by the energy, but also careful strategic planning. There are so many risks for incomplete ablation. For example, larger tumor or smaller tumor, or irregular, inconspicuous tumor, and subcapsular, perivascular, peri-organ tumor. This is a risk for incomplete ablation. But we have many solutions. We can use the strong weapon and use the contrasting ultrasound. Check the details. There are so many items we should consider, from tumor size and location, and electrode path, and up to post-history. Tumor size, number, and configuration, tumor irregularity, microvascular invasion, tumor location, subcapsular, perivascular, or peri-organ, electrode path, ultrasound visibility, intercostal space narrowing, and perihepatic momentum, coagulopathy, cooperation, comorbidity. And also, we should decide which energy we should use, which applicator, number, location, power time, puncture site, etc. Moving on to accurate execution, accurate ablation. I'd like to say 7 principles for perfect liver ablation, from never rush your procedure to verify immediately after your ablation. Let me go over one by one. First, never rush the procedure. Always pause before starting generator. Make one more look ahead. Speed impresses, but precision cures. Second, respect the planned trajectory. Follow the pre-planned path precisely. Even small deviation can compromise margins. Millimeters of deviation lead to centimeters of failure. Third, maintain continuous monitoring visualization. Use real-time imaging ultrasound fusion at all times. Avoid blind zones. If you don't see it, you don't control it. Next, confirm before ablation, very important. Reconfirm needle tip position before starting ablation. Ensure proper tumor coverage and margin. Ablation begins only after confirmation. 5, secure the ablative margin. Minimum 5, ideally 10 millimeter circumference ablative margin. Adjust strategy for heat sink or difficult location. We don't ablate just tumor. We ablate up to margin. 6, adapt to real-time feedback. Monitor echogenic changes and impedance. Respond to patient feedback. Execution is dynamic, not static. Finally, verify immediately after ablation. Perform immediate imaging CT or contrast ultrasound. Do not hesitate to perform additional ablation. Never finish until perfection is confirmed. Moving on to ablative margin. Circumferential ablative margin from 5 to 10 millimeter is really a critical factor to achieve the best result, our local ablation therapy. Recently, one recent paper, the consensus paper regarding ablative margin, you can see in this paper, Lancet Oncology, very detailed guideline. The forgotten secret of main limitation of our liver ablation. As we all know, our technique for acute placement of electrode is not so much accurate than we have expected, even for experts. We should remember. This is the critical limitation of our technology. There are many challenges to achieve circumferential ablative margin. First, most of index tumor is not truly spherical and not always conspicuous in ultrasound. Second, many more tumors doesn't have the exit for electrode placement beyond the posterior margin of the tumor. This is very important. Third, to insert along the exact central axis of tumor is extremely difficult. An assessment tool to assess the real central placement of electrode is also currently limited. And finally, overlapping ablation with a single applicator is not accurate due to being Sony window. This is our limitation we should overcome. Again, most of our index tumor is not truly spherical and not always conspicuous like this. And many more tumor doesn't have the exit for electrode placement beyond the posterior ablative margin. Many more tumors doesn't have the exit for electrode placement beyond the posterior ablative margin. And also to insert along the exact central axis of tumor is extremely difficult, even for the experts. And also, assessment tool to assess the punctual central placement of electrode is currently limited. Let me show my case. This is not big tumor in segment 7, but the margin is irregular. That's why I don't use a single applicator in my project. I choose the multiple RF electrode. This is the way to overcome the limitation of difficult central placement of single electrode. The first electrode, I place the medial margin of the tumor first, like this. And then second electrode, insert interolateral margin of the tumor, so-called no-touch technique. A little complex, but we can get more reliable result. Finally, third electrode, superolateral margin of the tumor, like this way. This is for my practice, very common for irregular margin, inconspicuous tumor. 6 minutes later, you can see the optimal ablation from with a sufficient ablative margin. This is concept diagram, like this, no touch, and centripetal ablation, like a hemangioma-like ablation. Okay, take home please. The conclusions are similar, right? First, know yourself first, and precise timing is important. Accurate placement, complete ablation, and balance between the safe and complete ablation. AI is coming, but we have to wait. Until AI becomes truly integrated into routine practice, the essential precise liver ablation remain in our hands of ablationists. Conclusion, precision is a mindset, not just technique. Thank you for your attention.
Thank you for your nice presentation. Any questions